Welcome back to Limitless Detroit. I'm your host, Seth King, and I am really, really psyched to have Dr. Tom Nabity with us today. Tom, it has been a long time, man. We've been kind of working together with different patients along the years. And you are, as I refer to you with everybody that I talk to, you're the expert on everything regenerative medicine. You own Michigan Center for Regenerative Medicine. Am I saying that right?
Yep, that's correct. Yeah.
And I'd like to hear a little bit more about you, and let's start with that. Like, what's your educational background? How in the world did you get into this realm of medicine, especially?
Well, thank you. Yeah. So we go way back. Love seeing the growth your business has had.
Awesome,
Similar kind of growth our business has had. I'm a physical medicine and rehab specialist, so it's a non-surgical orthopedic specialty. Subsequently did some pain management training, which is essentially guiding needles into pain generators and trying to block them with something that prevents pain. So whether it's a cortisone shot, which is what most people are familiar with, epidural steroids, common nerve block that we do for people with neck pain or back pain. But that's my core training. Then mid 2015, 2016, got introduced to the concept of regenerative medicine, which is very similar in a skill set to the pain management skill set, driving needles into specific targets. Rather than injecting those targets with something that blocks the pain, you try to inject those targets with something that stimulates a healing response so that you can actually fix the problem through a regenerative process rather than just masking the pain from the problem. Certain conditions have options that are regenerative, certain conditions don't, and over the course of the next 7 to 10 years, we've learned quite a bit in who responds, how do they respond, how well do they respond. So I feel like myself, and you explained that I was the expert in regenerative. I'd be the first to say that myself and my two other partners, we learn new stuff every day, and we all three are very collaborative in our approaches. When we have a case that we don't really have a clear-cut plan on what to do, we'll run those by each other, and so it's really great having colleagues, because it's a great space to be in, but it's an evolving space, and when you feel like you're on an island, sometimes it can get a little lonely and overwhelming. So having partners is really a key part of growing regenerative medicine in a way that's really patient-focused and outcome-focused.
I appreciate your humility. I think it's still like just to give you more than what you're giving yourself. Like it's the mark of integrity, though, when someone says they don't know everything, right? And I'm drawn in particular to healthcare professionals that admit that. So I think it's very telling that you're kind of saying it that way, because we don't know. We don't know anything with like ultimate certainty. I understand that. And hopefully today we can kind of dig in a little bit to some of the future of what regenerative medicine is going to look like, and hopefully we can cover some of those topics.
Absolutely, yeah.
I'm curious, like there's a lot of differences. You've mentioned it has a lot to do with injecting a pain generator or a needle penetrating into a pain generator. What are some of the biggest differences, though, between regenerative and just traditional medicine approaches to that particular topic?
Yeah, so the idea of this functional unit, so rather than thinking it as a cartilage defect as an isolated problem that needs to be either operated on or injected and blocked, you think about all the ligaments, all the tendons, the muscles that work on the joint. So if it's a knee, let's say a focal osteochondral lesion on the femoral condyle, something like that, which we see. Rather than just doing a chondroplasty where you go in there and operate on the chondral defect, or doing a cortisone shot where you put a needle in the joint space and try to block the pain from that chondral defect. Let's look at the medial meniscus and the medial collateral ligament. Let's look at the quadriceps tendon, the patella tendon. These structures that get lax, like ligaments, or like rubber bands that have been stretched too much. And by injecting those, you tighten up those rubber bands and you turn that knee back into the functional hinge joint it's supposed to be, rather than a joint that's sliding or gliding that's leading to a chondral lesion. So the regenerative mindset isn't a single try to minimize the injections. You actually want to look at the entire joint and all the structures that contribute to that joint functioning like it's supposed to, so that the chondral deficit can heal and not come back.
That's profound because I think there's a lot of people out there that are looking for options in the medical world that do not involve the letter S, like surgery, right?
Yep.
They're looking for not just another drug to put in their body too, but something that actually addresses the root cause of the problem. I know that's certainly what we try to do on the movement side of things, but it's an interesting example to use that. Like, are you saying that regenerative properties that you inject help to, you use the word tighten, I think is what you said, right?
Yep.
They actually help to change like ligament?
Through stimulating collagen formation. So it activates fibroblasts, which are cells that make collagen. Collagen is a protein that gives structural integrity to our connective tissues, so things like ligaments, tendons, cartilage, and it stimulates that collagen formation, which essentially tightens the rubber band.
Yeah, I think that's something that people do not understand, that like how much potential our bodies actually have for change like that.
So just the physical medicine rehab specialty, our primary specialty, works in conjunction with physical therapists, occupational therapists, speech therapists. So the idea that the body has the ability to heal itself through exercise is something that we've known and preached for a long, long time, which is, that's what you do every day, right? We're restoring blood flow, restoring proper movements, we're letting the body's natural healing properties get to that degenerative tissue so that that tissue can heal. When the body just isn't capable of getting enough cells there, an interventional regenerative medicine specialist essentially goes and harvests the cells from somewhere, concentrates them, and puts them where they need to go to give that body just that extra shove. So it's really, it's a continuum of care when you're looking at regenerative therapies. And PT is a big ball, like we were just looking at dry needling. Yeah. There's regenerative medicine properties in dry needling. It helps with blood flow. It helps with stimulating healing response through micro traumas. Right. So it's all regenerative. It's just to a different potency, and certain conditions can be well treated with this therapy. Certain conditions need a more invasive or more extensive therapy.
Sure. So what, and we'll get into some of the main couple of things that at least you and I have worked together, both PRP and stem cell. But before we get there, like what's the candidacy requirements for someone who's looking for something like this? Like, is it active individuals only?
No.
Is it sedentary as well?
Yes.
Like what's the inclusion criteria for someone to get some sort of treatment like this?
So the inclusion criteria is pretty broad. Okay. The things that stem cells don't do, or the things that regenerative medicine and as a whole doesn't do, is dissolve things. You're trying to regenerate tissues, but if you have a bone spur, per se, that's hitting a tendon. A classic example is a rotator cuff. You got a spur coming from the acromion, it's hitting that supraspinatus tendon as it passes underneath. Okay, we inject the supraspinatus tendon, we get healing of the supraspinatus tendon, but we don't anything about that bone spur, that barb that's sitting there cutting it. Well, it's just going to come right back, if not never heal in the first place. Yeah. So those conditions, you need somebody to cut that out, a surgeon, to cut those things out. Large disc herniations in the spine would be another example. Bony stenosis from facet joint spurs. Oh, yeah. So those would
all
be
very common things. Yeah.
So those would be things that we'd say, all right, well, probably stem cell or regenerative medicine isn't going to be your solution, but we can guide you down these other pathways to get that condition treated, and then maybe we do a stem cell regenerative medicine after the bony obstruction has been removed, to restore that function, just like we talked about, that functional unit, tightening up the ligaments, getting the structure to form and move the way it's supposed to, because that bony obstruction has been removed. Other exclusion things would be things like active cancer, active infection, somebody who's just hemodynamically, meaning their respiratory and cardiovascular systems aren't capable of undergoing anesthesia. Right. Those would be exclusion criteria. But those are pretty typical, just general. Anybody undergoing any kind of medical procedure probably wouldn't be a candidate for those.
Okay, fair enough. Yeah. Fair enough. Well, let's dig into like one of the most common things that I am aware of, at least, which is platelet-rich plasma therapy, PRP for short. I guess number one, just walk us through the mechanism of PRP therapy. How does it work to promote healing in the body?
So I like analogies. Hopefully that works for the audience and whatnot. So PRP essentially works the same as what happens when you cut your skin. So you get a cut on your skin, platelets stick together, they form a clot, they stop the bleeding, and then they degranulate. They release all these signals that are entrapped on the platelets, and your body hears those signals and says, oh, we have damage, and it mobilizes reparative cells, reparative tissues, things like your mesenchymal stem cells, MSCs, to the area, and then they, in turn, have more signals that then they send out and tell the native cells that are damaged, hey, time to start growing, dividing, and healing. And it kicks those processes up such that your skin grows back together, your blood vessels regrow, your other connective tissues come together, your cut heals, your wound heals, and your skin looks normal again. So it's that same process that the platelets can stimulate by taking blood out. So we do a blood draw to get all your blood, and then we put it in a centrifuge, and we separate your blood such that the heavy stuff goes to the bottom when you put it in a centrifuge, lightweight stuff goes to the top. The platelets end up sitting in a middle layer, layer we call the buffy coat, and then using either some sort of tabletop centrifuge, or in our office we use hand manual processing with pipettes. We're able to isolate that middle layer. We can get into hopefully this in a bit. One of the key variables to getting a good outcome is making sure you have the right dose. So in our clinic, we're going to count that cell, that cellular product, that platelet-rich plasma, to find out how many platelets are in it, as well as how many white blood cells, what types of white blood cells, how many red blood cells. And in our clinic, we have certain criteria we want to make sure that that sample hits before we then take that sample and inject it back in to the patient. So that same process that stimulated that healing response with the analogy of cutting your skin, if I take those cells and put it in, let's say your rotator cuff, it's going to stimulate a healing process that's going to make rotator cuff tendon, because these signals and these cells don't know what they're actually a signaling cell. They're not a stem cell that's actually going to grow into tissue. They're a cell that signals the native cells to grow, divide, and heal. So whatever tissue you inject is the tissue that ends up healing.
Yeah, that makes it really clear. Actually, that's helpful to understand that. So they're not becoming the cells themselves, which is maybe what we'll talk about with stem cell down the road.
Yep.
It's literally just a messenger process. They're saying, hey, mobilize, grow, divide, become more tendon, essentially, in that rotator cuff tendon.
It's the natural processes our bodies have.
Yeah.
It's just augmenting it and stimulating it so that it kicks into high gear.
Right. I mean, that's somewhat of a similar mechanism to what happens with things like loading and other external processes that we see during exercise, right?
Yep.
The remodeling on the cellular level for a tendon or for a piece of connective tissue that we see people go back and get repeat imaging on, that things have healed up, is done from loading, which I'm assuming is a similar signaling process to kind of what you're talking about.
Yep.
But you can be hyper specific. And like you said earlier, this is obviously going to be really, really beneficial for someone who kind of needs that nudge in the right direction too, where maybe they've not been a good responder to other things as well.
Yep.
Does that sound right to you?
Yep. Most of our patients have been through traditional regenerative type treatments, therapies, and they just haven't responded. And now, rather than the S word, surgery is their next step, they're trying this as an intermediate phase. That would be our classic patient.
That makes sense. What are a few? Let's say maybe top 5.
Okay.
Top 5 main conditions that you see benefit from this.
So knees for certain. That's our first one that we see the most of. Knee osteoarthritis, disc degeneration, annular tears. Put those into one category.
Yeah.
So lumbar spine in particular.
Sure.
Rotator cuffs, partial thickness or non-retracted rotator cuffs do really well. Tennis elbow lateral epicondylitis is just a home run, because almost never are those completely retracted. They're almost always partial thickness tears. Kind of the same condition, just different areas, medial epicondylitis.
Sure.
Seen a lot of Achilles tendinopathy, chronic Achilles tendinopathy, plantar fasciitis, another real good one. Hips, the hip osteoarthritis with our new injection technique, where we actually inject under the bone. Our outcomes on our hip osteoarthritis patients have gone way up. But
under the bone is
labral tears. So actually, just as if you were putting a gamma nail or a greater trochanter nail from a hip fracture. So it's the same process. You just go through the greater trochanter right up the femoral neck, into the femoral head and then inject the stem cells underneath the femoral head.
Wild.
So it's a new concept that's probably been 4 years now at our clinic, and came out of a doctor in France who's been treating avascular necrosis, which is a condition that the bone actually is dying from lack of blood flow and trauma.
It's an emergent. It's an emergency situation for a lot of people.
It can be. Yep.
Yeah.
Yep. So through his data and his technique, on the worst cases, we're now able to start extrapolating that into the less severe cases, earlier onset, earlier treatment. But the concept and the idea is those chondrocytes, those cartilage cells. While we like to think of the cartilage that sits on top of our humeral head or our femoral head, any of those long bones that have a cartilage cap on top, we like to think that's cartilage is separate from the bone. In reality, those cartilage cells get their nutrition and their origin underneath the bone, and then they migrate upwards and they become that cap. So again, analogies, to me, it's like growing leaves on a tree. And if you're trying to grow more leaves, you're not going to spray the tree with fertilizer. You're going to jam it into the root. So it's the same idea.
It's a pretty good analogy, honestly.
Injecting it under the root, and it stimulates that healing from the inside out, and that cartilage, sure enough, grows and becomes a cap that sits on top of the.
That's fascinating.
On top of the bone.
Okay, I love that. All right, so you brought this up. You brought up this doctor in France. So I'm going to take us off course just momentarily. We'll get back to PRP, and I want to talk about stem cell and peptides and as much other as we can. But I actually kind of put out a poll on Instagram earlier today asking for people if they had any specific questions about what it is that you do, about regenerative medicine and all. I got this question from a couple of people actually, which is that they've heard famous people. So think of Joe Rogan, people like that, that are talking about other countries and other states potentially being able to get like a higher density of things like PRP, higher counts, and in that they weren't allowed to do that in the current location that they were at. So I'm hoping, I'm curious, can you speak to what is going on, what's going on in our country around that, and not necessarily only PRP, if you want to expand on anything else, but you mentioned this doctor in France. There's a lot of other stuff happening in the regenerative world outside of our country and not currently allowed inside of our country. Could you comment on that?
Yeah, so there are some regulatory guidelines that the FDA has given us, and understanding FDA's role is patient safety. It's society's safety, and their guidelines for regenerative medicine are the numbers are called the 361 guidelines. So they have the tissues have to be homologous, meaning they have to be used for the same purpose that they are in the body. They have to be autologous, so you have to take it from the patient and put it back in the patient. So using donor cells, like a placenta cell or umbilical cord cell in the United States is not in within the FDA guidelines.
Right.
Whether it's legal or not, it depends on whose interpretation of the law that you want to go with. But in our opinion, it's playing with fire, and you're asking to get in trouble.
Sure.
So we don't offer autologous products at our clinic, and it has to be minimally manipulated, and that is a pretty black and white, like what things they've said are within minimal manipulation and which things are not. So you can centrifuge, you can wash, you can use a phase separator to separate water-soluble and fat-soluble items. But you can't use like an enzyme, or you can't grow them in culture, wait a couple weeks, and then inject more cells. So right now, I think what you're alluding to is more with the stem cell world than the PRP world, where patients are going outside the United States so they can get culture expanded cells. So in other words, if I were to do your procedure here, I would take stem cells out of your body. I'd use my minimal manipulation techniques to concentrate them. I would count them. And let's say, on average, I'm usually going to get about 10 million stem cells from a patient that we're doing. And if I was able to culture expand them and then re-inject you 2 weeks later, I might be able to get 100 million. So 10 million to 100 million. Is there going to be a bigger outcome? Is there going to be a better outcome? And until we track our outcomes and check our dosing, we won't know. With
So
PRP,
still pending,
it's still pending,
yeah.
whether that culture expansion step is necessary for a better outcome or not. It's an extra step, so there's extra risk involved, because not only can you culture cells and grow cells, you could also culture bacteria.
Yeah, that's
and
right.
grow bacteria. So it's got to be done in a super sterile environment. One of those ideas where you're walking in two different chambers. The first chamber you're getting sprayed down, putting on a spacesuit. Second chamber you're going in and growing these cells, which is expensive.
Sure.
So the cost, there would be an added cost to doing a culture expanded version. And most of the clinics outside the United States are double to triple what our costs are at our clinic. And that's most likely related to that culture expansion process. Is it worth it? I mean, who cares if it's 3 more times if it's going to give me a result that I can't get with what we're doing? That's where we need the data, because we do have a lot of good data on PRP with that in that regard. So the stem cells I quoted were 10 million versus 100 million, and platelets you're talking in the billions. So if you have 500 million platelets versus 12 billion platelets, we're actually able to count those, and we're seeing a significantly statistical difference in patients, and the dose that they're injected with definitely drives better outcomes.
Okay.
And what we haven't seen yet is a point where that starts to go down. With most medications, it's a bell curve. Too little, no effect. Too much, side effects. We want to find that optimal dosing range.
100%. Yep.
Biologics are probably similar. I think that therapeutic window, that dosing range, is probably really, really wide. But at some point, you can probably get too much inflammation, let's say.
Sure.
One of the things with COVID was, the cytokine storm that patients can get the cells into, and that's one of the potential causes for mortality. There's this condition called graft versus host with transplant patients or donor, when you're getting donor cells, which is one of the kind of going all over the place here, but one of the reasons not to use donor cells and to use autologous cells is that you can't get a graft versus host reaction. But could there be some sort of a condition where you're injected with too many cells and your body doesn't like that, and it goes into one of these like cytokine storm situations? So all reasons why it's important to know the dose that you're being injected with, and that it's a dose that's been studied, it's a dose that's relatively safe and are known to be safe. And we just kind of slowly walk that dose up over time.
So that's really insightful, actually. I think that's a good level of detail. And along that road, I mean, I remember years ago when we first met, you talking about the difference in the way that you process some of these cells is that you are able to measure the dose.
Yes.
Is that common in those that do PRP?
Is
that uncommon?
It's uncommon. I would say it's still less than 50% of clinics that are regenerative clinics are counting the cells. It's probably even, sadly, less than probably 10%.
Okay.
The regenerative medicine world is still somewhat in its infancy. It's gaining more and more traction and legitimacy within the traditional healthcare world. Third-party insurance payers still haven't come around to paying for that yet, but I do think that time is coming relatively soon. And one of the key components is the third-party payers want to know a dose. If they're going to pay for a procedure, if they're expecting or having reasonable expectations for a positive outcome, just like I can't hand you an 81 milligram aspirin and expect your headache to go away.
Right.
They don't want you to be given a sub-therapeutic dose of PRP and expecting somebody's rotator cuff to get better.
Makes sense.
It's not going to. It's not the right dose.
The whole conversation about dose, I mean, that just has me thinking about exercise too. I think exercise is obviously a very good thing. Resistance training, for a quick hypothetical example, is a very good thing for building tissue capacity, which is this phrase in tendinopathy that we know all about. Mm-hmm. But you can do too much of it, even though it's an amazing thing, even though it's regenerative inherently. You can do too little of it as well. So even in our clients with tendinopathy, we're constantly, and I know you support this with the messages I hear from patients saying, make sure that they push you. I hear that from a lot of them. But one thing that we often see is that, and some of the research supports this as well. Jill Cook in our world is kind of like the head of a lot of the tendon research. But too little mechanical stress does not yield enough actual change. Too much causes too much irritation and pain. Like you want this middle ground, which is uncomfortable. It's an uncomfortable amount of load, but it's not too little, not too much, right? So that's that. I see that when you're talking about that bell curve, it's kind of the same thing. We're talking about dosage of exercise. So I think it makes a lot of sense. Anyone who's experienced an overdose in anything related to movement has experienced, really intense soreness, or I'm sure some of the same risks exist. Likewise in regenerative medicine.
There's a lot of recurring themes in this regenerative world, whether it's, you're talking about injections, whether you're talking about exercise, whether you're talking peptides. There's a lot of similar themes.
For sure. Well, so if we could stay on PRP just for one more brief question. And I know this is really general, but I am curious because this is not something that I have my nose in all the time, and it is, you do. What does kind of the current literature say about efficacy around PRP?
Yeah.
I'm sure there's some percentage numbers that might be helpful for people to hear. What's a decent summary for us?
Yeah, so globally, 85% of our patients are having success. That's probably the easiest, quickest
It's a big number.
answer. It's a great number. So how do you define success? Right, so that's critical. You get it there. So we want to see 80% improvements in pain and function. We don't always get post-imaging, so depending on what we're seeing, we can't always throw an ultrasound probe on it and see it really easily. We have to order an MRI, and sometimes if people are better, why we get an MRI just for curiosity standpoint.
Right.
So tissue change isn't always criteria for defining that 85% success rate, but always the pain and function outcome scores.
Well,
so 100%.
I'm sorry to interrupt you, but tissue change is not always even correlated with what we understand about pain.
That's a key
concept.
concept.
Tissue degeneration is not always coordinated with or correlated with pain even.
Correct. Yeah. Correct. Yep. So that's the thing that most everybody wants to see, is that structurally things look better, but that's not always the case. But just because they don't look better doesn't mean they aren't better.
Right.
It's the function, it's the internal tissue integrity that doesn't always show up on an MRI and ultrasound machine.
Sure. So it helps a lot. It helps the majority of people.
So the vast majority of people, yeah. And my partner, Dr. Santana, just presented our dose response data at one of the national conferences, TOBI. Really kind of a big deal that he was up there presenting that.
That's awesome. So you guys are on the front end of this as well, publishing.
We're in there. Yeah. We're in there with a lot of other like-minded physicians. We're not the only ones certainly around the country doing this, and it's nice to have those societies that share ideas, share data, help promote the field for the right purpose, which is developing less invasive strategies to get people better outcomes.
That's a great summary right there. I like that. All right, well, if we could, let's move on to stem cell therapy.
Okay.
This is, I don't know if it's controversial, but once again, I run into many people in my world, even athletes, who are hungry for this type of thing that have not really heard about stem cell therapy. So if you wouldn't mind, give us a brief overview of what that is, maybe also how does it differ from PRP?
Sure. So stem cells are a big term. There's a lot of different pluripotent, omnipotent, multipotent. So the types of stem cells we're talking about here are not the omnipotent. That would be like a human embryo, for example, meant to become every cell in the entire human body. So the types of stem cells we're talking about here are mesenchymal stem cells. So there's 3 germ lines that develop our human tissues, and the mesenchyme is one of those lines of tissues. So all things connective tissue come from the mesoderm or the mesenchymal cell line. So everything that's orthopedic, tendons, ligaments, cartilage, muscle, bone, all can be stimulated to heal through these mesenchymal stem cells. So 2 main sources of mesenchymal stem cells, donor, allogenic, and your own, autologous. We touched a little bit on right now in the United States, only the autologous are the ones that we're able to use. So 2 main sources in our body for those mesenchymal stem cells, bone marrow and fat. In the fat, you get the adipose cells, and it's not actually the adipose cells where the MSC's stem cells are, it's the vascular beds that are in the adipose cells. So it's the same vascular beds that are fed from the bone marrow. It's the same cells.
Yeah.
The benefit to fat is, people like to have their fat aspirated. The benefit to bone marrow is
Interesting. Yeah.
it's where they're manufactured, and we can do a cell analysis and a count on the bone marrow. We can't do a cell analysis on the lipo. So it's a little bit of a restriction in knowing what dose we're using. So for that reason alone, same quality cells. At our clinic, 90+% of what we do is bone marrow derived because we can quantify it. Now there are studies showing that for the same aspiration amount, you get more stem cells from fat than bone marrow. As soon as we have an ability to actually count that, that would be something that might change our clinic and how we're choosing our product. But right now, for the vast majority of our patients, bone marrow is the best source. By getting that dose, we're able to know that it's one of the 3 variables to getting a good outcome. Make sure that we're checking that box and make sure we're getting the right dose. So, question was stem cells in general. The allogenic sources, umbilical cord, placenta, I think have great potential. We're just not able to use those right now in the United States.
Okay.
That would be another thing I would love to compare equal doses, a donor cell to your own. I'm gonna put my money on your own because of that whole graft versus host thing.
Yep.
Assuming you're in relatively good health.
Makes
That
sense.
might change if then you're treating a condition that, like an autoimmune disease condition or something outside of a musculoskeletal disease, where maybe a donor cell would work better than your own.
Yeah, I can see that. Some select situations, but we don't have data really to comment on that too much right now.
Definitely don't have data to comment on that yet, and I know clinics that are using autologous for those sorts of conditions and that are using allogenic. They're all outside the United States, but both clinics seem to be getting favorable outcomes. So it'd be awfully nice if we could get some comparative head-to-head data, knowing which cells work better for what conditions. But too early to tell. The good news is, you know, as highlighted on like Rogan's podcast and some other podcasts, people are getting results.
For sure.
It's not just smoke and mirrors. There's some real science there.
Real change too. So really, you drew the comparison earlier of PRP as more messengers, right? They're signal makers that are causing multiplication within the tissue that it's already embedded in or injected into. Whereas stem cells actually have potential then to change into these different cells.
So that is one of the misconceptions of what these mesenchymal stem cells do, which is one of the reasons they never become cancer. Nobody's ever had a single report of using mesenchymal stem cells and turning on some sort of cancer growth, because they are also strong signalers that tell the native cells to grow, divide, and heal. So if you put, and the study that probably proved that the best, if you put a radioisotope on these mesenchymal stem cells, MSCs, and then track them over time, you can scan them and see, over the course of 6 months, they're all gone. None of them have developed into cartilage cells. But what they did in that 6-month time frame is stimulate the native cells, the chondrocytes, to grow, divide, and make more cartilage. So it's pretty interesting that PRP and MSCs actually work very similarly through a mechanism of stimulating a healing response.
Yeah, that's fascinating for sure. I remember, again, when we first talked about this years ago, you made the comparison of potency as one of the primary differences as well, right?
Yep.
Like PRP, potency of that here, stem cell potency higher, right?
Yep.
So break that down for us if you wouldn't mind. Like, what is there a way to quantify that at all? Do you have any idea?
So there's certain conditions that respond almost equally to stem cells and PRP, and there's certain conditions that are vastly different. And in my experience, the ones that have the tissues that have a really good blood supply, a rotator cuff, for example, do almost equally as well with PRP as stem cells. PRP is injecting a signal that recruits stem cells, and then the stem cells tell the cells to grow, divide, and heal. So let's say you inject a PRP and you're able to get 10 stem cells there, or 10,000 stem cells there. And if you went and did a bone marrow aspiration, you're going to get 10 million stem cells there.
You're going to put them right there.
And you're going to put them right there. So you're always going to get more stem cells to the targeted tissue if you do a stem cell treatment, a bone marrow or a lipoaspirate. At what point is enough? and you don't need the added invasiveness or the added cost of a stem cell, and you can get away with a PRP, a less potent procedure. So we do try to do a real good job in our consults of educating people to say, hey, your condition does almost equally as well as PRP and stem cells. I'd recommend just do the PRP.
Interesting. Yeah. Okay. So there is that well known at this point? Like which conditions do respond better to one than the other?
I wouldn't say well known from
Yeah.
a data standpoint yet. It's one of the
Sounds
next
like it.
papers that we're trying to mine. So there's these databases that us and other clinics around the country import our data into, so that we can track comparing, by pooling all our data, we can get a much bigger patient base. And so then you can start looking at, all right, severity of condition, what was injected, what were the outcomes, and you can really start drawing lines and conclusions. So we can confidently tell people, hey, you have this type of a tear, 70% chance with PRP, 80% chance with stem cell. And then patients can make their own educated decisions
Sure.
on whether that extra 10% is worth the extra finances and invasiveness.
Sure. Interesting. I appreciate the level of detail there. That's
Yeah.
great. I have another question from social medias.
Yeah.
Right? The internet wants to know this. For just, it sounds silly, but I've been asked this many times and not really known how to answer it. Which is when someone goes through a PRP injection, let's say, or stem cell, it's really very similar question in nature. Where does all of it go? So in the main question was asked today.
Yeah.
It seems to be that there's like a mandatory like inactivity period or like a little bit of rest that you need to do after. But do the cells just gradually disperse away from the area? Do they fade and get dissolved into other tissue around them? Or how do we know that they really stay put where you're actually injecting them? Does that make sense?
Yeah, so there have been studies where they put these radioisotopes on and they look, and sure enough, like they don't all stay right where you inject them.
Right.
Vast majority do, but they do leak out. They certainly get absorbed in the lymphatic system and the blood system and migrate and go elsewhere.
Okay.
But they're localized certainly for the first 5 days, specifically to that area. And in that 5-day period, they're stimulating an inflammatory response, which is what then kicks those cells, those fibroblasts, then to activate and start cranking out collagen. That process takes a month for the fibroblast activation to ramp up.
Are the stem cells still active that entire time during the month?
They're still active. Their signaling is subsiding.
Okay.
But they're still active and sending their signals, as they will throughout about a 6-month period. So there's still continued signaling that slowly tapers down over a 6-month period. The rest is relative to kind of where people were beforehand. So let's say you're running and jumping before. Okay, I'm going to have you stop doing that. But
Excuse me. Yeah.
if you're a relatively sedentary, walking household distances, there's not going to be any restrictions. You can, again, it all depends on what we're injecting: a spine, a shoulder, a knee. But you can move the joint. You can do basic ADL daily activities, but no aggressive activities for the first month. And then we start that rehab phase, where we want to start progressively loading the joint, loading the tendon, whatever tissue was injected, so that you tell the body where the weak points are to make sure that it reinforces it with the collagen.
Makes sense. Awesome. All right, well, that's a good answer for that, I would say.
Yeah.
All right, so I guess before we move on from PRP and stem cell, I'm going to guess you probably have some good success stories. Do you have anything that comes to mind with either or with both of them of something cool that happened, or like a truly like great outcome that happened?
Yeah, I mean, we have, a lot. It's
What are some that stick out in your memory?
The spine ones stick out in my memory for certain. One of the first patients we treated with a disc issue was a young, late 20s, 28-ish-year-old, active duty reserve in the Air Force, who for almost a year couldn't be deployed because he couldn't carry his rucksack and pass his PT deployment. And after a year of not being non-deployable for a medical condition, they gave him 2 options. One was a 2-level fusion, or the other was a medical discharge.
Oh, jeez.
And
That young.
He didn't want to be medically discharged. He still wanted to. He was a good number of years in, and you know, if you can get to your retirement,
Absolutely, yeah.
it's
his career.
It's a big important thing. So we did a stem cell in his lumbar spine, and after 3 months, he was able to start carrying his rucksack again. After 6 months, he was able to pass his PT test, and he's still in the Air Force today. He's someone
that's awesome.
that we worked with, or we still work with, and he's yeah. So that one really stands out.
That's so cool.
I mean, plenty of knees, plenty of, you know, the Olympic athletes that we treated that were able to compete in the Olympics last year. That was really rewarding to see her.
I know you're skating around it because you can't say names.
Yeah,
but I appreciate it though. Yeah.
I guess, you know, myself, I've benefited from Dr. Santana. My partner injected my lumbar spine. I had degenerative disc at between 4.5 and 5.1, and kind of dealing with daily soreness and pain and stiffness, and starting to limit my ability to work out. And that was December of 2022, so we're almost 2 years out, and I kind of forget I had a back issue.
That's
awesome.
awesome.
It just kind of melts away, and then you're doing everything you want again. And yeah, sure, I might get an ache or a pain here or there, but who doesn't?
That's the truth.
But it's not like the daily thing. I was, you know, taking Motrin every night before bed, and just don't even have to do that anymore.
Yeah, man, the relative risk of Motrin, even, right, NSAIDs in general,
Yep.
like, is not without risk. I think a lot of people look at that as a just like this easy, non-risky thing to do, and it's quite the opposite.
Yep.
From GI problems to cardiovascular. It's
Yep.
not great, right?
Yeah.
All right, well, let's move in. A few more minutes here. I want to talk about peptide therapies.
Okay.
Now, this is something I'm not real well versed in, but I do understand there's been, like, one of the most basic ones, BP157, right? There's been some FDA problems around it as well. I'm curious, maybe from a 5,000-foot view, can you give us a look at how is that separated a little bit from PRP and stem cell, if it is at all? Like, and what are some of the most common ones that you do? But then also, you know, what issues are we having with peptides in this country in particular?
So I guess starting for the 5,000-foot view, what is a peptide? Think of it like a hormone. So it's very similar. I mean, most everybody understands hormones are naturally produced from our body, and they're signals that our body sends from one area, usually some sort of a gland, to some end tissue. So let's take, you know, growth hormone, for example, is a common one that people have heard of. Comes from the pituitary gland. It has various different functions, but one of them is to go to the muscles and stimulate muscle growth, or, you know, testosterone or estrogen or progesterone, all of those hormones. Thyroid, people are familiar for the most part. So
Sure thing.
a peptide is essentially a hormone. It's just a shorter amino acid sequence, so it's a shorter chemical equation than the hormones. But they're naturally produced by the body for specific purposes, to stimulate some sort of a end result in a tissue. So the one you alluded to, BPC-157, stands for body protective compound, and it's secreted from the lining of the gut, and it helps with the gut turning itself over, because there's a lot of trauma that goes in our digestive system. So those cells are constantly turning over. So it helps with cell turnover. It helps with growing connective tissues. And when taken and injected systemically, it can help with connective tissue healing and connective tissue repair. So things like tendons, things like ligaments. So how does it coincide, or where does it fit in with PRP or stem cells? It's definitely adjunctive or augmentative. It helps that healing cascade go even a little bit more. But it can be a standalone therapy for lesser severe treatments. Even more intriguing is now people are starting to, and me included, inject it specifically into target tissue rather than just injecting it into the skin and letting it go everywhere. If you have a rotator cuff tear, why wouldn't we put it close to the rotator cuff? If you have a joint problem, why wouldn't we put it in the joint space? And it seems to be helping patients when injected locally. So it's a little bit of a gray zone right now with the FDA. There are some restrictions with compounding pharmacies and the exact version of BPC-157 they're able to make.
Okay.
But they've been able to, for the time being right now, get around that by using a slightly different version that still binds to the same receptor, but it just has a different enough chemical equation that it gets around the ban. So why that ban was put in place is I think still a question that a lot of people have different answers to. I don't have a good answer. I certainly don't know anyone in the FDA personally to get any kind of insight, but their public statement is safety concerns. I haven't seen any negative effects from it. Any of the studies I've read, I haven't seen negative effects to be from a safety standpoint. I think the potential concern there is making it in batches in a compounded pharmacy rather than a commercial grade mass producing pharmacy.
Sure.
They might be concerned about there being batches that get contaminated, but I can't. I'm just, hypothetically speaking.
Just guessing.
Just guessing at this point.
Yeah.
I don't know why that it is right now a more difficult compound to get than it was 2 years ago, but it's still available.
What other peptides are more common out there? Or maybe a few of the most common.
So there's another the growth hormone. Peptides help our body produce more growth hormone naturally. So growth hormone comes through the pituitary gland, and these are growth hormone secreting peptides. So they tell the pituitary gland to push out more growth hormone. That one seems to help patients both with their training, the people that want to push the limit on their performance, but also people recovering from surgeries. Another one, thymosin beta 4, is one that seems to really help boost the immune system, which also then in turn helps with tissue repair. That's a common one we prescribe a lot.
Interesting. So it's certainly not just the PPC 157 that everyone seems to know about, probably just from some other podcast somewhere, would be my guess.
Yeah,
right?
yep.
What's to stop you from using all of these simultaneously? Because it seems like there's a lot of options.
There's so many
PRP,
options.
There's stem cell, there's all these peptides that all, quite frankly, sound like they do incredible things for our body. But there's some reason you don't just prescribe all of it at one time, other than cost, I'm assuming.
Other than cost is the main thing. At what point is it overkill?
Yeah.
And I don't like recommending things that patients don't really need.
Yeah.
And when you're talking about things that your insurance isn't covering, I think it's really important to be forthcoming and honest and say, hey, this is where your value is. If you really want to do everything possible to heal, I would add this next, this next, this next, this next. But I don't want to seem like I'm overselling or telling people they got to do everything. Because in reality, we're getting great outcomes, and we're not doing everything most of the time.
Right.
More patients are becoming more aware about peptides, and we're getting more questions about it, and we can field those questions very easily. But I will say, patients that stack their regenerative procedure with a peptide tend to do really well. I can't say tons better. I don't have enough data yet because that's not one of the variables we're tracking as to whether people took peptides or not for their outcomes. And we probably should to have that be part of our registry.
Sure.
But right now it's not.
Okay. That's fair. That's fair. So I'm sure you get a lot of common questions and concerns. Like cost is obviously something that's always, being that it's not a covered service through any insurances, is it? In the country?
Some injury-based insurances, like an auto or work comp, will cover it. But those are the only ones.
Yeah. Well, so I would imagine cost is a common concern. Also, people want to understand what are side effects of regenerative techniques, because there's probably some level of documented side effects that you guys have as well, right?
Yeah. So there's pain is the main one.
Okay.
Increased pain, expected for usually 3 to 5 days. I've had it last up to 2 weeks. It's almost always self-limited. We can control it with pain medicines, and it can affect your ability to go to work or perform activities of daily living, but it's usually very tolerable. So the biggest, most common thing is just increased pain for a couple days afterwards. Infection's always a risk anytime you poke the needle with or poke the skin with a needle. So proper sterile technique, really important. We've never had an infection we have some for the more risky procedures, we use IV antibiotics, very similar to what you do when you get a surgery. So fortunately that hasn't been an issue for us, but it'd be a theoretical concern as needle placement. So knowing that you're putting the needle where it needs to go and not hitting a nerve or hurting a blood vessel.
Sure.
So trained hands and interventional pain is important, knowing the anatomy, knowing how to visualize not just the structures you want to hit, but also the structures you want to miss,
Right.
and watch your needle go right to the structures you want to hit.
Makes sense. That makes sense.
Cost, it's, there's a variable span anywhere. I would say the probably least expensive procedures start at like $500, and our most expensive procedures go up to almost $10,000. So
Right.
it just depends on what product we're using. Stem cells cost more than, say, prolotherapy. What equipment we're using, if we have to drill into bones versus if we're using 1.5" 22 gauge needles to hit a lateral epicondylitis. So there's
Very different.
factors involved.
Sure.
Of equipment, invasiveness, and then OR time and staff.
Yeah.
Do we need to bring in an anesthesia team for this? Are we taking up the operating room for an hour and a half for this? Is this a 10-minute procedure that needs one medical assistant? So all those factors come into the cost as well.
Makes sense. Makes sense. All right. Well, I want to close us out with maybe a couple of things just about the future of regenerative medicine.
Okay.
So this is your world. Like, what are you most excited about that is on the horizon as far as you can see it with regards to regenerative medicine?
Culture expanding autologous cells.
Yeah.
I think that's
what you were commenting on
I
earlier.
think that's right around the corner, and really excited to see the difference between outcomes that we're getting with people injecting. On average, we get about 10 million cells, and if I can culture expand them to the kind of number being floated out there right now is 100 million. If I can get 10 times as many stem cells, what's that going to do to my outcomes?
Yeah.
And I think what we're going to start seeing is a lot more tissue change on our post-imaging. So we kind of talked about not always tissue changes, doesn't always, just because your rotator cuff tear doesn't heal doesn't mean you're not healed. But I think that might be a function of how many cells we get. I think we get it, if you're looking at the generative slide, I think right now we call it regenerative medicine, but really we do a great job of halting that degenerative slide. So we're pausing the degeneration. We get a little bit of a regenerative curve, but we're not getting people back up to normal 20-year-old cartilage. Can we? If we have more cells? That's what I'm really excited about.
That's cool. That's cool. I can see why you're excited about that. That'd be a pretty amazing thing.
Same injection technique, same patient base. All I'm doing is injecting with a bigger dose, and I really think we're close to having that available.
Makes sense. All right, so I always joke we're gonna do this segment called "It's Getting Personal," sponsored by. No, I don't actually have a sponsor for this, but at one point we will, man. It's gonna be a coffee shop probably, right? But no, I'm curious, just like for a more personal touch, like what inspired you to actually go down this road of regenerative medicine? Like, is this born out of a story of your own health, or just professional interest? Like, what's the deal there?
Frustration with patient outcomes.
Yeah.
Pain management doctor, getting anywhere between a 5 and 10 year program, you tend to collect your failures. And the people that come to you in pain that you're able to fix with a pain shot, a proper rehab program, and their problems go away, they don't come back and see you. The ones that you can't fix with those things, and then they have surgery and they're still in pain after surgery, they come back and see you whenever they need their medicine refills. And over the course of 5 to 10 years, you collect all your failures. Not that you failed them, it's just the people you couldn't help.
Yeah.
Because your schedule starts to fill up with all those patients that you couldn't help, and now you can't get the ones that you can help into the schedule.
Yeah.
So looking at that patient base and just knowing there's got to be something else out there, seeing the literature of the regenerative medicine world starting to come through in our PM&R journals and our other pain journals, and then I had a patient ask me about it, and I said, well, this was about 2015. I said, I think it makes sense for you. Like, you got a condition that could respond to that. Let's find somebody in the area doing it. Went on this website called Google and couldn't find anybody in the area that I thought had the right training or knowledge base. It just didn't seem like the right degrees and
Sure.
specialties behind their names. So at that time, Hines Ward he was a wide receiver for the
yeah.
Pittsburgh Steelers in the Super Bowl. He was able to play the Super Bowl because he had this thing called PRP. And I happened to know the guy that treated him, and so I sent this patient down to him. And long story short, that patient came back 6 months later, and I thought he needed another cortisone injection in his knee. He's like, "No, doc, I just want to tell you, thank you for sending me down there because my knee is so much better. I don't need your shots anymore."
Oh man.
And I was like, okay, if there's really nobody in
How
Metro
common
Detroit
was that for you?
doing it,
Yeah.
why don't I become the guy? So I kind of did a little road show. I did a really impressive conference in New Orleans, put on by the American Academy of Orthopedic Medicine. Met a really kind and generous doctor down there, north of Minneapolis, who said, "Come up, watch me work, see what I've done." And went up there for 3 days, watched his clinic, saw his skill set, saw what he was doing. It's like, I can do this. I came back home and started.
That's awesome. That's a great origin story right there.
Yeah.
How common was it for you in PM&R realm to have someone come back just to say, "I don't need these shots anymore"?
Never.
Like that's the polar opposite of it, isn't it?
Yeah.
That's wild. I
Yep.
appreciate you sharing that. That's
Yeah.
cool. That's cool. So for people that are, obviously you are in Rochester Hills. You serve obviously a larger radius than that, but for people who are in our area and in Detroit Metro at all that want to connect with you and that want to seek you out for your services, what's the best way for them to get a hold of you?
So we're Michigan Center for Regenerative Medicine. Should find us pretty easily on any of the search engines, but we're regenerativemedicinemichigan.com is our website. Phone number 248-216-1008, and we do telemedicine visits, so happy to, anybody who's not in Metro Detroit, if you're just curious if this might be something that could help you, we'd be happy to do that telemedicine visit, and even if it means feeding you to one of our trusted colleagues somewhere else in the country, if it's too far to fly or travel to us. But we do get a fair number of people that travel certainly across the state and the kind of this area of the country,
Sure.
from Chicago to New York, upstate New York, we get clients. So
Awesome.
happy to take a look and try to find you. If we can't service you, find somebody in your area that could.
Perfect. Well, appreciate your time.
Yeah,
Appreciate
thank
going
you.
on.
Thanks for having me.
Yeah,
This
for
is
sure.
fun.
Maybe we'll have another conversation down the road about something more specific.
I got a lot more
but
topics.
I'm sure we could talk about any one of these things we could have talked about for 30 or 40 minutes on
Yeah.
our own. So appreciate you kind of diluting it for us for
Yeah,
now.
of course.
Awesome.
Thank you.
Appreciate it.
Yeah.